Welcome to our video on septic arthritis. Let's get started. Here's our overview slide. We'll discuss the definition, pathogenesis, risk factors, and clinical features of septic arthritis. We'll then highlight the condition of disseminated gonococcal disease, and finally wrap up by discussing the diagnosis and management of septic arthritis. Let's begin with the definition. Septic arthritis is an acute infection of a joint. It's most commonly bacterial. The most common pathogens are Staph aureus, Streptococcus, and Neisseria gonorrhoeae. Neisseria gonorrhoeae is the most common pathogen of septic arthritis in young, sexually active adults. Alright, moving on to pathogenesis. Bacteria can invade the joint space via multiple ways. First is the hematogenous spread. Second is the direct spread from contagious infections such as osteomyelitis. And third is the direct inoculation of pathogens, for example during trauma or an arthrocentesis. There are many risk factors associated with septic arthritis. These include advanced age, prior joint damage such as osteoarthritis and rheumatoid arthritis, as well as immunosuppression, for example diabetes mellitus, recent joint surgery or trauma, and finally IV drug use. The clinical features include a swollen, warm, and painful joint, limited range of motion, and fevers or chills may be present. Here's an image showing a swollen knee joint. This can be seen in the clinical presentation of a patient with septic arthritis. Before we move any further, let's talk about an important condition, which is disseminated gonococcal infection. It results from the bacteremic spread of Neisseria gonorrhoeae. There are two classic presentations. One is a triad of tenosynovitis, dermatitis, and migratory polyarthralgia, and the other is isolated purulent mono or oligoarthritis. In the diagnostic approach, blood culture should be obtained. Synovial fluid should also be obtained and sent for analysis. However, the preferred diagnostic method is the nucleic acid amplification test, or NAT, and this should be used for Neisseria gonorrhoeae in urogenital, rectal, and pharyngeal specimens. The treatment is with IV ceftriaxone plus oral azithromycin. Oral azithromycin is added here due to treat the presumed concomitant chlamydia infection. Here's an image showing skin lesions in a patient with disseminated gonococcal disease. Note the gray pustules right here. Now, using this algorithm, we'll review the diagnosis and management of septic arthritis. When a patient presents with a swollen, warm, and painful joint, septic arthritis is suspected. We should then examine the range of motion. If it's not limited, other diagnoses may be considered, such as cellulitis or osteomyelitis. However, if there is limited range of motion, the next step is obtaining blood cultures as well as joint aspiration. Radiographic imaging can be considered to assess the adjacent bone and to have a baseline assessment of potential joint damage. Synovial fluid should be sent for analysis. Based on gross appearance, the color, white blood cell count, and percentage of neutrophils can help identify the type of arthritis. If the synovial fluid is yellow and transparent with a white blood cell count of less than 2,000 and less than 25% neutrophils, this suggests a non-inflammatory arthritis, such as osteoarthritis. If the synovial fluid is yellow and transparent to opaque with a white blood cell count of more than 2,000 and more than 50% neutrophils, this suggests an inflammatory arthritis, such as rheumatoid arthritis. If the synovial fluid is red and bloody with a variable white blood cell count and 50 to 75% neutrophils, this suggests hemorrhagic arthritis. Finally, if the synovial fluid is yellow to green and opaque with a white blood cell count of more than 5,000 and more than 75% neutrophils, this suggests septic arthritis. At this point, the next step is to initiate IV empiric therapy based on gram stain analysis of the synovial fluid. If it shows gram-positive cocci, vancomycin is provided. If it shows gram-negative diplococci, suggesting gonococcal arthritis, then ceftriaxone and oral azithromycin are provided. If it shows gram-negative bacilli, a cephalosporin is provided, such as ceftriaxone, cefotaxime, cefepime, or ceftazidime. However, sometimes the gram stain shows no organisms. In these cases, certain elements of the patient's history need to be assessed prior to initiating empiric antibiotic therapy. If the patient is immunocompetent and there are no other confounding factors like trauma, then vancomycin is provided. If the patient is immunocompromised or there is evidence of injection drug use, then vancomycin plus ceftazidime or cefepime are initiated. If septic arthritis is due to trauma, then vancomycin plus a third-generation cephalosporin are initiated. Finally, definitive antimicrobial therapy should be provided according to culture and susceptibility results once they're available. All right, let's try a question. A 60-year-old male presents to the office with increasing knee pain over the last 4 days. He has a history of gout and type 2 diabetes mellitus. On synovial fluid analysis, the gross appearance is purulent. A gram stain is positive, crystals are present, and a white blood cell count is 85,000. What is the next step in the management of this patient? All right, here we have an elderly man presenting with monoarticular pain. The patient has a history of gout, so this puts a gout flare in the differential diagnosis with septic arthritis. Our patient has two risk factors for septic arthritis. One is his history of diabetes mellitus, and the other is underlying joint disease, which is gout. A synovial fluid analysis shows the presence of crystals. However, this does not exclude septic arthritis because crystals can be present in synovial fluid between gout attacks. Additionally, we know that a typical gout flare usually takes 12 to 24 hours to reach maximal severity. Therefore, regarding the increasing pain over 4 days, along with the positive gram stain and a white blood cell count of 85,000 on synovial fluid analysis, we should think of septic arthritis as a more likely diagnosis. And the next step in management is IV empiric antibiotics, which should be based on gram stain findings until culture results appear. If the synovial fluid in our patient had not been purulent and the gram stain had been negative, along with the presence of crystals, we would have treated the condition as we would do in a gout flare. Here's an image that shows synovial fluid from a septic joint. Note the gross appearance, which is yellow and opaque. Here's a microscopic slide with gram staining. It shows purple cocci in clusters. The purple color tells us that the cocci are gram positive and the pathogen is likely Staph aureus. Here's another microscopic slide with gram staining. It shows pink cocci distributed within and outside of neutrophils. The pink color tells us that the cocci are gram negative, and the likely pathogen in this case would be Neisseria gonorrhoeae. All right, let's wrap up with a final question. A 28-year-old man presents to the office with severe pain in his left knee. He states that the pain started suddenly last night, and he denies any preceding trauma to the region. He also complains of a fever that started simultaneously with the pain. He is sexually active with multiple female partners and inconsistently uses condoms. He drinks alcohol occasionally but does not smoke. His temperature is 38.6 degrees Celsius, blood pressure is 125 over 82 millimeters of mercury, and heart rate is 98 beats per minute. On physical examination, his left knee is swollen, warm, and tender. Passive and active range of motion of the left knee is limited. Inspection of his arms reveals several intravenous punctures. What is the best next step in the management of this patient? So we have a young man presenting with pain in the left knee that started suddenly without preceding trauma. The patient also has a fever and the knee is swollen, warm, and tender with limited range of motion. These findings strongly suggest septic arthritis as the most likely cause. The most essential step when suspecting septic arthritis is obtaining synovial fluid to be sent for analysis. So the correct answer is C, synovial fluid analysis. Recall from our algorithm that when a patient presents with symptoms that raise suspicion of septic arthritis and there is range of joint motion that's found to be limited, the next step to perform is joint aspiration to obtain synovial fluid, as well as obtaining blood cultures. A is wrong because an X-ray can be considered to assess the adjacent bone and the joint damage. However, this is done after confirming the diagnosis of septic arthritis, so it would not be the next best step to evaluate our patient. B is wrong because an MRI of the knee is most useful for evaluating soft tissues and would surely not be a first step when suspecting septic arthritis. D is wrong because empiric antibiotics should be initiated after obtaining synovial fluid. So again, it's not the best next step in our question. And again, the correct answer is C, synovial fluid analysis. And that concludes our section on septic arthritis.